Hi guys, for our presentation today we'll be talking on warm antibody autoimmune hemolytic anemia. So firstly, what is autoimmune hemolytic anemia? This is a rare condition in which the red blood cells is destroyed triggered by the autoantibodies reacting with the antigen, and then this occurs with or without complement activation. The classification is into three. One, the warm antibody autoimmune hemolytic anemia. Two, cold agglutinin syndrome. And three, paroxysmal cold hemoglobinuria. What is warm antibody autoimmune hemolytic anemia? This is the most common type of autoimmune hemolytic anemia. It occurs about 70 to 80% in adults and 50% in children. It is a condition in which the antibodies attack and destroy its own red blood cells at a normal body temperature of 37 degrees. A brief mechanism of how this happens is that it is when the antibody, usually IgG, binds to the red blood cell antigen and marks it for destruction. The causes of warm autoimmune hemolytic anemia is divided into two, the primary and the secondary causes. For the primary causes, there is no specific etiology being identified which results to warm autoimmune hemolytic anemia. But the secondary cause, this is recognized as lymphoproliferative syndrome. Lymphoproliferative syndrome is the abnormality that occurs in the proliferation of the lymphocytes. The etiology and the secondary causes includes malignant disease such as chronic lymphoblastic leukemia, non-Hodgkin's lymphomas, and solid tumors. 2. Rheumatologic diseases such as systemic lupus erythematosus, and infections and also drugs, which includes cephalosporins and piperacillin.
So moving on to the pathophysiology of warm antibodies causing hemolytic anemia. So for this to occur, there are certain mediators and conditions. This mediator is the autoantibodies, which are in the form of IgG, and then you have complement proteins, macrophages, and the spleen. The condition is that it should occur at body temperature, which is 37 degrees Celsius. So firstly, the body produces autoantibodies, which are the IgG, that mistakes self-antigens that are present on the red blood cell surface as foreign and attacks it. So for this to occur, it's at body temperature due to the fact that IgG have a high affinity towards red blood cells at body temperature. So next, these IgG antibodies, they tag the red blood cells and then transports it to the spleen to be destroyed. The tagged red cells will attract complement proteins along the way, which are C3 and C4. They bind onto the cell to make them targets by immune cells. And these immune cells are none other than macrophages. So the destruction of the autoantibody coated red blood cells is mediated by the macrophages' phagocytic activity. The anemic person will present with spirocytes seen in their blood smear. This is due to the partial phagocytosis that macrophages do. And the degree of spirocytosis correlates with the severity of hemolysis. Then moving on, we'll go on to the clinical features that are seen. And this is related to the pathophysiology, where we know red blood cells are damaged. So you expect your hemoglobin, your HCT, and your red cell count to decrease. And not only that, you'll also expect to see jaundice, since there's a buildup of bilirubin, and the patients will also present with very dark urine, since there is elevation of indirect bilirubin. And they'll also have splenomegaly. Splenomegaly, this is due to the overworking of the spleen, since it keeps filtering the damaged cells. And then patient will also present with tachypnea, tachycardia, and angina, which is chest pains due to the decrease of oxygen supply towards.
Hello, so I will be discussing on warm antibodies causing hemolytic anemia, especially on the live diagnosis and the treatment. So quick recap on two main symptoms. Firstly is splenomegaly. In hemolytic anemia, the spleen overworks due to continuous red blood cell destruction, which leads to spleen hypertrophy, and over time it can also cause splenomegaly. The second symptom is jaundice. So jaundice is due to increased hemoglobin breakdown in the blood, so it leads to increased unconjugated bilirubin in the blood, which is one of the laboratory diagnosis. The diagnosis we can find the hemoglobin and hematocrit low, because in the hemolytic anemia there is premature destruction of red blood cells, so it does make sense that hemoglobin and hematocrit will be low, and reticulocyte would also be low, and also in the blood film we can find spherocytes. LDH is also high because it is high in LDH isoenzyme, so when red blood cell ruptures it releases LDH into the plasma. The next laboratory diagnosis is haptoglobin. So haptoglobin is low because in hemolytic anemia it binds to the free hemoglobin in the lysed, from the lysed red blood cells, and it is rapidly cleared from the body. Lastly, the direct antiglobulin test is tested positive for IgG antibodies. Next, moving on to the treatments. Severe cases of hemolytic anemia, we can do blood transfusion. The second treatment can be prednisone. So prednisone, it suppresses the immune system and to prevent productions of autoantibodies. Next line of medication is rituximab. It is a monoclonal antibody that acts against CD20. Next treatment is splenectomy. So splenectomy is the removal of spleen, because spleen is the primary site for production of antibodies, and also a primary site for red blood cell destruction. So splenectomy is only considered when a patient is resistant or steroid dependent, and it is resistant to rituximab. Another choice for treatment can be hematopoietic stem cell transplant and folic acid supplement. So yeah, so that's all from laboratory diagnosis and treatment.
Thank you. I'll be talking on the last portion of our digital poster, which is the case study. And our participant consists of a middle-aged individual with no prior medical history. His symptoms, or he presented with the following symptoms: anemia, fatigue, pallor, and possible jaundice. He was later diagnosed with warm autoimmune hemolytic anemia through positive DAT and evidence of red blood cell destruction. So he was given treatment, which consisted of corticosteroids and immunosuppressants, in which the patient responded well and his symptoms seemed to improve. So the patient's immune system, we can say, mistakenly attacked and destroyed the red blood cells, which led to a decrease in the RBC count. This led to some confusion, or made the diagnosis a bit difficult for physicians. The patient was treated with immunosuppressants to suppress the immune system and help reduce the destruction of red blood cells. Moving on, upon treatment with other medications, including steroids, the red blood cell destruction also seemed to decrease, and the case showed how diagnosing and managing this condition can be complicated, especially when standard tests don't give clear answers. So the patient still responded well to the treatments upon which he was given. So that concludes our digital presentation this evening. Thank you.